Okay, so I think we're going to get started. First of all, I'd like to welcome you all to our first in-person Yale IR grand rounds that we've had in a long time, I guess, since the pandemic started. And I'm really honored and pleased to have one of my good friends from the interventional radiology community and an all-around good guy, Dr. Chuck Martin from the Cleveland Clinic, who's going to be speaking to us today about some topics that I find extremely interesting and some things that we really, I think, should invest here in eventually to make Yale IR even better than it already is. So just to give you some background, Dr. Martin is currently on staff at Cleveland Clinic. He did his, I guess, undergrad at Johns Hopkins, his medical school at Case Western, and he did his, I guess, residency also at Case Western, correct, in Cleveland, and then did his fellowship here at Yale, so he's actually an alumnus of the program here. And then I guess spent a little time in private practice, what I understood, for a couple of years, and then saw the light and went into a much more academic job, which is at Case Western. For years, I've now known him, and it was kind of secondary to being on an advisory board for a device company. And we had some interesting issues related to the company that we used to speak about, at length, but that's an aside. But it does bring up the idea that with these companies, there is a lot of interest in development and advancing the field, right? So that's where we're going to eventually go in a few minutes. So Dr. Martin has a lot of interests. He is the IR liaison to the HHT Center of Excellence at Cleveland Clinic. And he's been involved in a lot of other interesting topics, which include interventional oncology, embolotherapy, medical device development, also augmented and virtual reality, which we are going to hear about today, and also a lot of educational strategies for medical students and residents. And it's interesting because when we talk about virtual and augmented reality, a lot of the vendors are now demonstrating this. And one of the vendors told us about a company, MediView, that he's currently the chair of the medical advisory board. That I didn't notice at the time, but when you go to RSNA, you're playing with all this device development and equipment, and you're wearing the goggles and stuff. And it turns out that it was his company. I'm not going to give you the name yet. He can do it if he wants. But he also has a lot of prominent positions, which include now he's currently the president of the Ohio Radiologic Society and a whole bunch of other organizations, including being involved heavily with the ACR. So with that, we were nice to, I like to invite Dr. Martin to talk about augmented and virtual reality in healthcare and interventional radiology, which includes the current applications and hopefully future directions. So thanks. Thanks.
All righty. Thanks so much, David. And thanks everybody for coming. This is real nice and an absolute honor to be back. I can't believe it's been so long, but it's kind of crazy how fast time flies. I'll kind of launch right into kind of the topic, just kind of talking about augmented and virtual reality and kind of where things go. So I'll kind of we'll move on through right here. Here are my disclosures, kind of relevant and non-related and non-related, I should say. And I just want to kind of level set. So real quick, by a show of hands, how many people have actually put on a virtual reality headset? Nice. All right. This is actually really impressive because when I kind of started working in this area about, I guess now about 6, almost 7 years ago, I'd had maybe 1 to 2 hands up. So that actually made me very, very happy. So just to kind of get a sense for kind of the spectrum, my research kind of falls a little bit more on the augmented reality, but I actually have quite a few projects also on the virtual reality side. So I just wanted to kind of put this up here just to kind of show everything from, obviously reality to augmented reality, where you actually, you're still looking at things in real time and the real world, you just have additional information kind of in your field of view, or kind of augmented it, all the way to virtual reality, which is a complete virtual environment. But this is it's also kind of crazy to think that the ugliness of that first headset that was really kind of clunky and such. Now kind of this is what we have here with the the Oculus, the Facebook, or I guess Meta Oculus Quest line. So we'll start kind of talking about virtual reality, and we'll kind of move over a little bit more towards the augmented reality side. So especially within healthcare, you kind of see it in pretty much these 6 areas. These are kind of like the main areas where VR is kind of used in some way, shape, or form. And it's actually something that I could talk about forever, but I think that there's a lot more you could do. And then when you kind of pair that with what's going on really in the digital health revolution, you kind of see all of these things, but especially patient-centered, it kind of falls by the wayside, just because a lot of it focuses on everything else, but kind of what we really need to work on, which is kind of the patient interactions. And when you look at kind of like how it evolved, like you essentially had from 1965 with the first headset, a commercial headset first in the 80s, and now we're kind of here where honestly the neuro world has actually kind of been pushing this forward a little bit more even than a lot of other areas, especially around kind of stroke, PTSD, things like that. And these are kind of I kind of put this slide up there just because it's really kind of wild, all the different places where you're going to kind of see augmented or virtual reality pop up, and they try to do it in one way, shape, or form, whether it's education, ADHD, pain, orthopedics, those are stroke, as we've mentioned. Those are all areas where it's actually kind of actively used. And when you kind of think about it, you can kind of break it down into kind of like all of these kind of major contexts here: kind of learning, retention, muscle memory, kind of present and context, and then kind of motivation and engagement. And you can kind of see some themes already kind of coming out. And one of the things that we've actually kind of looked at the clinic, you'll have like a lot of these mental health apps that are out there. Everybody and their cousin are kind of promoting one or the other, but at the end of the day, there's actually a huge dropout rate. And what's fascinating is that like it's very kind of temporal. You'll have people who will use them. They may even get over, like, let's say, an acute episode, but there's the retention is actually awful. So patients may use it for a little bit, and then it just really kind of falls off. And there's no consistent engagement. And kind of truthfully, VR has kind of been one of the ways where that can actually happen a little bit more. And then even further, when you're talking about kind of medical education here, we working with the Case Western team, they actually have a hollow anatomy modules that, especially during COVID, they'd kind of moved to a complete virtual holographic system where the medical students there could learn anatomy and different skills training, things like that. And it happens also Case Western. We worked with the organic chemistry group, and they can kind of manipulate molecules and proteins as well. And this is actually some of the most forward-thinking work in VR right now. Is actually the UCLA group. They do some really interesting work around pediatric resuscitation, pediatric psychiatry, PTSD, and phobia work, and we'll kind of get into that in a second. And when we start actually getting into kind of how this could be used in medicine, I mean, this is another area where I think it's just kind of ripe for innovation and kind of activity. I mean, virtual standardized patients. Right now we still, I mean, there used to be kind of a joke at the clinic that we would have like our very standardized patients that every person would see through medical school. And now you can kind of do this, and students can actually work on this at home, so they can actually kind of continue to kind of get better, instead of having these like very kind of focused interactions and then kind of fall away. So you can really actually improve engagement and actually really kind of assist people if they're, let's say, not so good at some of the emotional components. And this is the other part. I think that this is one of those areas that I personally think kind of see one, do one, teach one is not, I suppose, not adequate, and certainly not always appropriate. But I know personally, like the first time, for giving, bad news, I was just asked to go with somebody, and I kind of watched it, and then I did my best to kind of model after that, through a few other scenarios. There was nothing that was out there that was actually very kind of dedicated. Now we actually have like a VR training simulation where we can actually do that, and then you can kind of grade people on it. And then kind of getting to some of the other areas, we have some of the activities for daily living, PT and OT, and the orthopedists have really kind of actually pushed in this capacity in a whole lot of ways. If you don't mind, I actually have some colleagues from industry who gave me a few of these slides, and this kind of helps to kind of track a little bit about what's going on. So some of the engineers that we work with at HP, when you start to look at kind of the opportunities that we have, there's so much data, within the real world, as well as kind of that feedback that you get once you put on that headset, that we're actually not able to kind of capture. And truthfully, through these headsets and through in the virtual space, we could start tracking this, whether it's eye movement, excitement via pupillary reflex. I mean, there's a ton of data that you can actually kind of get back and forth that, we're missing. And, this is just kind of one of the ways that the company is kind of working on it. And, just kind of for improved interventions. This is kind of some of the preoperative planning, image guided surgery work that's being done in the VR space. And, we all know one of the companies up here, they're big in the coil area and thrombectomy area, but they actually also have one of the leading VR products for stroke. It's really kind of interesting. It's a little bit of a departure from their normal stuff, but like a lot of kind of stroke therapy and kind of understanding where patients are and what they can do, has actually come out of their work. And then, kind of using the virtual environment. I apologize. Can everybody see the top there? I'm just kind of actually noticing that click more. Where is that? Hide video panel. There we go. Okay, cool. So, we could use these virtual environments to kind of treat, all sorts of kind of mental illness, health problems. Especially around anxiety. That's a big one that gets, you're actually able to get some great work on. And then VR and AR for pain distraction. I mean, I know it's a very kind of rudimentary concept, I know, but this is certainly an area that, especially in the pediatric population, we're actually able to get really good traction. Truthfully, this is one of the projects that I'm working on now is just, essentially for kids, we put them in a headset, and we've kind of, as they're kind of getting chemotherapy, they kind of shrink down to the size of a red blood cell, and they get to kind of flow through their bodies and kind of start to kind of kill cancer cells. And the kids love it because it kind of keeps them, engaged and active, and they don't think about like this, the poison going through their body. And truthfully, they understand the process a lot better. So that's always really kind of encouraging. And obviously PTSD and phobias and anxiety. Now, truthfully, some of this work, which was being advanced at UCLA, actually pretty aggressively, it actually just got put on hold about 3 months ago because somebody actually had a psychotic break. It's really kind of wild because you can make these experiences so vivid, so realistic that you could really kind of see some pretty wild things. And truthfully, it was over like a kind of a spider phobia. A patient just kind of it was a little bit too much for them. It was a little bit of a blessing and a curse. I mean, we in the industry, we kind of felt like, wow, this is really here and this is really kind of helpful. But at the same time, it was kind of like an unfortunate side effect of some of the work. And obviously for training of medical professionals, there's so much being done right now for like in the VR space for just kind of letting people walk through surgeries, especially in the orthopedic space. Most recently, there's a company that has received almost $100 million in funding, and essentially all they do is they partner with orthopedic device manufacturers, and like their ortho residents, they basically just kind of run through total hips and total knees again and again and again, to the point where you'll have a resident who will walk into an orthopedic surgery and they'll ask for that specific device. So they've effectively figured out a way to kind of monetize this whole process, and they're doing it really effectively, and residents, by the time they're actually walking in to do their first total joint replacement, they actually understand it a million times better. And this is a company that I know I'm personally kind of working with right now. They're Luxonic, and we do some research right now with a sorry about that, looking at actually a virtual reading room. It's a project that's kind of a little bit of a work in progress, but essentially over the course of the pandemic, they've been actually able to effectively figure out like how people read, and then they can kind of simulate that. We put our residents through that, and they actually kind of enjoyed it. We actually had pretty much a bunch of RSNA simulated cases, and they were actually able to run through it. They were able to put comparisons up, and they enjoyed it, because a lot of times, if let's say you'd have kind of attendings who some of the better attendings who like to teach, sometimes they weren't available, or sometimes they were at home. You can actually kind of just plug in, and then they can actually watch this. And it was really kind of cool to just kind of watch them, really kind of engage in this virtual format. And I mean, honestly, what's nice is, especially for the diagnostic teams, you can kind of start doing this anywhere. So the company itself, they've already had approval over in Canada, but the thought is to kind of obtain the same approval here. And you could actually start having diagnostic radiologists essentially kind of reading images on the beach. And this is just kind of what it kind of looks like when we were kind of working on different parts of it. And now kind of move along the spectrum to kind of on the augmented reality side. This is kind of the area that's especially near and dear to my heart. This is kind of where we went from kind of some of our benchtop work to actually some inhuman research. So essentially what we kind of did was used holograms, kind of a patient's own anatomy. We created a hologram from a patient's CT scan, overlaid it on the patient, and then performed procedures in an electromagnetic field. And I'll kind of show you this over the next whole bunch of slides. But essentially while we were able to do this, it actually allowed us to perform procedures faster. We feel a little bit safer, because some of the procedures had some interesting vasculature that was either in the way or some other structures. But our hopes when we were doing this, for the most part, we wanted to improve focus, anatomic understanding, obviously accuracy, and decrease the complication rate. Those were some of our goals kind of as we were kind of moving through everything. And a lot of this, unfortunately, because I wasn't exactly kind of classically trained in research. So a lot of it was like, we just kind of looked at each other in a lab, and we kind of started out, kind of looking at each other and said, can we do this? And then after that, we kind of moved into, wow, it actually happened, and it worked on a phantom. And then we actually progressed to being able to do this in human trial. And we realized that it actually can work in a whole bunch of different ways. So, a colleague of mine actually took this picture when I was doing a procedure. And, this kind of is pretty typical of any interventional suite, where, you kind of have a patient in front of you. Meanwhile, you're looking in some other direction at the ultrasound. And we just always, it's just a part of what we do. And, a lot of people just say kind of duh. And we just kind of learn to kind of fix our hands in one spot. So one of the first things that we were actually able to do was actually wearing the HoloLens. We can actually broadcast that image, actually the ultrasound image, in real time, and actually put that in our physical path. So there's no longer, kind of looking over here, looking across the hall, looking down here. You're actually able to physically look at your hands, just like any other operator who does other procedures, and actually perform a procedure, minimizing drift, minimizing, like all of the kind of fine motion that, we as IRs just kind of take for granted, and kind of, we're able to kind of get over time. And, kind of getting over to the nitty gritty of it, this is kind of our secret sauce and kind of how we did it. So we take a patient's pre-procedural imaging right here. We then kind of create a 3D model or a hologram. We then kind of push it through Unity, and then were actually kind of uploaded to the HoloLens right here. All the while, we have this electromagnetic generator, which is essentially it's just a board that goes, lays right under the patient. That's radiolucent, so it doesn't have any issues, in a fluoro table or a surgical table. And that radiolucent board kind of creates an electromagnetic field, kind of tracking everything we do. And the outcome is this 3D holographic guidance over here. And a little bit more about the platform. It's just using, for the most part, we've used Microsoft HoloLens, although we do these procedures using our Magic Leap systems as well for our AR systems. And this just kind of shows a little bit of the pre-procedural processing. So you'll essentially kind of have a tumor, kind of anywhere, in the different, in different organs. And then we just kind of essentially just kind of create a 3D image. And my colleague is going to kind of talk over a little bit of what we're doing here, because I'm going to start to kind of show a couple of videos.
After CT scan, digital models of fiducial markers, tumor, gallbladder, liver, vessels, and bone are pre-procedurally segmented from the CT datasets to build an app in the Unity editor. The challenging tumor location between portal vein and gallbladder show the need for hollow fusion.
And that's kind of a picture kind of showing the different pieces of the anatomy and the tumor there in yellow. I don't know why, but when we started, and it's kind of a joke amongst our group, but all of our tumors are yellow. And we just kind of use that to just kind of designate the tumors. It's just one of those things that's kind of helpful. So just as you kind of go through these pictures,
After CT
I'll kind of
scan,
show you this a little bit. Oh, sorry about that. But here's another kind of picture that kind of shows this, and I'll get into this a little bit later. But, as we're kind of doing these procedures, sometimes actually having a component of fusion could be actually super helpful. But, one of the other parts that's actually really helpful is that we can actually model the kill zone. So before we actually even put needle to patient, we could actually tell you, how big our target is, the trajectory that we're going to go, and how big actually the ablative area is going to be, and what that's going to look like post-procedure. And by doing that, it's kind of helped us to kind of effectively navigate, or even sometimes kind of change the trajectory at which we actually advance different instruments. And this is kind of some of the imaging right here, just kind of demonstrating a lot of that. And here's just another, kind of when we were planning all of this,
CT-based holograms and fiducials used for registration into the headset's coordinates are shown for an anthropomorphic phantom. Live ultrasound images extend from the electromagnetically tracked probe, and a holographic needle trajectory extends from the tracked trocar, also in headset coordinates. For accuracy testing, the holographic CT and live ultrasound guidance are used to navigate the virtual trajectory to intersect the target simulated lesions.
So when we were doing this, initially, just to kind of put this image up here, this was, right over here, this was our phantom. We actually just kind of ran our phantom right through the CT scanner, made a hologram of the phantom, and then basically kind of put that kind of ultrasound phantom on a, kind of on our electromagnetic grid, and then we were able to track everything. This is our trocar that we typically use for our procedures. A lot of times, because when we do ablations, we actually will take biopsy samples as well. So we'll actually just kind of use an outer trocar. So we've now kind of sensorized our outer trocars, and that kind of helps us track needles, hands, everything else that's in the field. And you can kind of see it moving here kind of the whole time. The other thing is that we've also kind of superimposed an ultrasound image. We call it kind of flashlight mode, but we can actually either put the ultrasound image kind of directly kind of coming down. So if sometimes our trainees like this, because then they're able to actually kind of see the plane at which the ultrasound is going to be, kind of projecting, so they can kind of figure out where to kind of traverse the needle. Or alternatively, it'll just kind of focus in our headset right there. And here's just some of the equipment that we use, essentially kind of the tracked probes, the pre-procedural CT spot markers for some of our initial experiments. And then, these were actually the registration markers right here. And this just kind of shows a little bit more of the tumor vasculature. This was, I guess, case 6. We've now done a little over 30. but I don't know if it's projecting well, but this was a really tough tumor to see. And truthfully, there was a lot of vasculature around it right there. So we were actually able to kind of saw it a little bit better under ultrasound, but there were still a whole bunch of vessels there. And we were actually able to effectively kind of target it, ablate it, and our area was kind of modeled right here. And this is just another video that just kind of shows kind of a different patient. And unfortunately, I apologize, try as I might, all of these holograms, they never really kind of project the way that I would kind of hope, but it essentially kind of shows, shows exactly what we were kind of getting at. And here it is again. I've used this for a lot of my cryo, especially because a lot of times when we're kind of either freezing either soft tissue tumors or renal tumors, I'm using multiple probes. So I actually find it actually pretty helpful just to kind of proceed with using kind of our modeling software, just because it'll actually kind of show me actually what the kill zone looks like. And you can kind of see it here again. We'll kind of toggle this ice ball right here off and on, and it'll kind of demonstrate, kind of where you'll see the tumor now once again in yellow, and then you can kind of see how we kind of use to kind of get to it. And we were actually quite accurate. We were able to actually nail this with just 2 probes, an ice pearl and an ice force. And this is another one that just kind of shows some of our intraoperative evaluation. This was another tumor that was, essentially kind of exophytic right off the kidney that we were actually able to kind of get to, kind of navigating around ribs and such, and being able to get there without it too much trauma. Fortunately, this patient had come to us just because they had essentially a complication, unfortunately, in an outside hospital where upon attempting a percutaneous access to this, one of the intercostal arteries was tagged, and this patient had come to me on call for an embolization, and they were talking about they had needed this embolized. So then we kind of used this just to kind of model it before we were able to successfully embolize it, or ablate it, excuse me. And this kind of shows it again, kind of taking the bone away, but you're actually able to just see like where the vasculature is, where the kidney is, and where the tumor is. And this is just kind of, overlying, and the patient's actually under there. But this actually shows us kind of exactly where we need to go and what we need to do. And honestly, the trajectory that we're taking. So it's pretty helpful. And this is essentially kind of what it looks like. So we have the real ultrasound right here. You can kind of see the real ultrasound kind of right there in front of you. But you actually see the holographic projection of that ultrasound just next to it. That holographic projection is now kind of what our trainees and some of my colleagues will use kind of instead of in lieu of the other actual ultrasound, because you don't actually have to take your gaze away. And this just kind of gets into some of the bench anatomy or accuracy, excuse me, demonstrating the anatomy. We were actually able to kind of prove that by performing these procedures, kind of using this system, that we were actually a touch, especially with our trainees on a Phantom, that we were actually a touch more accurate than actually standard of care. And truthfully, all of our patients were, granted now our trainees were a little out here, but the attendings, actually the group for path length, were a lot closer together, and there was fewer movements. And essentially, kind of while we were doing this, we had a whole handful of improved opportunities here, whether or not it was with targeting or treatment. And this is just kind of some of our patients and some of our results, basically demonstrating that we were able to kind of effectively improve outcomes. And in all of our completed cases, we actually were able to kind of confirm agreement between the hologram and the pre-procedurally planned trajectories there. And this is just that video again that will kind of essentially kind of show the entirety of the process here. But what this actually leads us to is kind of the next portion, which is our teleprocedure and telecollaboration. So I just wanted to kind of show this one more time, demonstrating all of our work here. And you can kind of, as we're toggling this anatomy off and on, it's all using voice prompts. So the way we typically will set it up, where we'll say tumor, bone, vasculature, and it all kind of toggles back and forth. And it makes it just easier because you're actually able to kind of use your hands the way you're hoping to use them, and you can actually kind of focus on the procedure a little bit more. And this kind of gets into one of our to me, one of my more important projects, and it's kind of teleprocedure and telecollaboration. In the process of us being able to transmit that ultrasound image holographically in the system, we started working with Microsoft, and what we realized is essentially Microsoft has a Teams product that works also for the HoloLens. It's just called Remote Assist. And what this has allowed us to do in working with them, we actually developed a module where we can essentially broadcast exactly what we see under that ultrasound image over a distance. So for fun, we actually just started by, I would use the ultrasound. I would do basic procedures, whether it was a paracentesis, thoracentesis, vascular access. And while I was actually using the ultrasound, I'd have a colleague in another room, in their office, in another building of the clinic. And basically they were actually able to see on their Cleveland Clinic iPhone exactly what I was doing. And they were able to actually kind of comment on it in real time. This is one of my colleagues right here, Diane. She was actually looking in, and she could actually see the ultrasound in real time. She could see my hands, and then she could kind of comment and actually make marks on the screen. And this is just kind of some additional images that kind of demonstrate all of this. This is actually a patient right here. We were putting in a Pleurex catheter, so we were just kind of looking at the abdomen. And you can actually see the ultrasound image right there kind of floating. We had several colleagues online actually able to do this. And I think it can have some really interesting applications, as Fabian, we've talked about this for a while, for over longer distances. And our hope is over the course of 2023 and into 2024, bringing this technology to rural places in the US and then internationally. Our hope is to kind of demonstrate that we can actually bring technology and transfer of knowledge over longer distances. And this was one of our cases. This is actually my colleague, Jacobo. He's actually down in Cleveland Clinic, Florida. So while I was actually actively doing a procedure, he was actually able to kind of watch me on the headset, and the whole process. And over the next few weeks, we actually have plans to kind of expand this actually through our Cleveland Clinic London facility, as well as Cleveland Clinic Abu Dhabi. But we're also looking forward to kind of hopefully at late 2023 or 2024 to partner with you to kind of bring this internationally. So kind of just in summary here, because I know I've been kind of talking for a little bit, we've found that it kind of decreases procedural time, it increases understanding, improves depth of perception, and improves confidence most all. And most importantly, we've been more accurate, we've been faster, and it's allowed us to kind of get better outcomes for our patients. And this is really kind of where I see the future of this actually kind of proceeding. And so thank you.